Good morning, everyone. So I think there is an inequality because you are fighting is a World War II, but here there is a Russia and this is a Ukraine. So there is a senior most person in a critical field, and I am the junior most person that you have ever seen on the stage. Okay. So I'll start my lecture that we cannot solve our problems with the same thinking we used when we create them. That means in life, if you want to change your vision or enlightenment, you require gurus, teachers that give you enlightenment and change your vision. So here I have seen Dr. Rahul Pandit sir, Dr. Ansari sir, Dr. Akhilesh sir, Dr. Gunnar Padi, all they were my teachers. And I am here on the stage because of them. So I'm very fortunate that I got all those gurus opportunity to work with them. With that, I will start my topic. That is cookbook therapy is enough. Let's not get fancy. First week in critically ill patients. Before I start my talk, first of all, we have to understand what do you mean by cookbook therapy, what do you mean by critically ill patient, and why we are discussing about first week and what is the clinical significance in a critically ill patient. So it's very important that cookbook therapy will give you a basic level of knowledge that is very important, not all the people having the same intellectual level in the critical care unit. Second thing, the advancement, the advantage of cookbook therapy is very straightforward and prescriptive. It will tell you you have to use this amount of calorie, this amount of protein, and you will get this outcome, a mortality benefit, or decrease ICU stay, or decrease ventilator stay. The third important thing is that the cookbook therapy will make your life easier for the inexperienced teacher like me and the weaker candidates. That's very important nowadays in current scenario. So before starting the war, it's very important that where am I fighting, why am I fighting, for what am I fighting, right? So most of the war happens just because they don't define the territory. So first I have to define my territory. What do you mean by critically ill patient? So in medical term and statistics is known as defining the sample. So that's very important. So I'll start my slides now. So define the critically ill patients. So there is no gold standard definition of critically ill patients. So it's a wide spectrum. It's a constellation of multiple disorders. So and another important thing is not all the patients come to the ICU are critically ill patient, because when I took the round with the Ansari sir, and sir is asking why this patient in the ICU is quite stable. There is no need of ICU. So that means whatever the trials that you are carried out in the randomized control trial doing in the ICU and labeling the patients as a critically ill, might be those are not critically ill. They are just there in the ICU for the sake of because of the primary consultant wants them. So, but still I took one of the definition by the Nets et al. That is any of the condition, a life-threatening condition that required pharmacological and or mechanical support for the vital organs without which the death is imminent. That is one of the definition you can take. It's not a gold standard accepted by all the fraternity over there, but that is one of the definition we can take. Now the second questions come to my mind, is the all critically ill patients are same as chronically ill patients? So that's also not well defined. There is no standard definition of chronic critically ill patient, because mostly widely accepted definition of chronically ill patient means the patient who is there in ICU for 21 days who requires a ventilatory support of more than 6 hours per day. But that is not the true definition, because there are some patients who are critically ill who are there in ICU for many days, but those doesn't require ventilatory support. That means we are not talking about this group of patient also. Then are we labeling critically ill patient as a starvated patient? That's also a myth, because as a student we always feel that all the critically ill patients are starved. Okay, that's not the true, because starvation is a totally different pathophysiology per se. Because the main difference here is the starvation is a hypometabolic state. Or when we are talking about nutrition in critical ill patients, it's a hypercatabolic state or hypermetabolic state. What's the difference over here in the pathophysiology? So in a starved patient, they primarily rely on a fat at a primary energy source, while in critically ill, they require carbohydrate and protein. So initially carbohydrate, followed by when there is a depletion of the gluconeogenesis and carbohydrate store, you rely on a lean body mass, that is a protein, utilization of the protein. So we are not discussing about this entity also. So ultimately, कहना क्या चाहते हो? So there is no standard definition of critically ill patients. So whatever I'm fighting with the Rahul Pandit sir, but the territory is not defined. Like in Russia and Ukraine, they are fighting. If you label them as a USSR, probably Russia is right. Ukraine is a part of it. Okay, so defining territory is very important. So now we'll move forward with next slide. That's why ESPEN guideline come into the picture in 2019, with the spectrum of the disease that we are going to see in critically ill patients. So if you see the at-risk malnutrition, they categorize like there is a disease with inflammation, disease without inflammation. You can see an acute disease, you can see the chronic disease. But even if you see in this slide also, you will not see an acute critically ill patient. So where can we put the acute critically ill patients over here? No, so there is no definition of acute critical illness associated malnutrition. I agree. So there is no standard definition of it. But the most important thing is that any of the patient who is there in critically ill area and who stayed the time of more than 40 hours should be assessed for the malnutrition. That is the overall agreement they come to the conclusion. The second thing is that when you are thinking of more than 48 hours in any of the critically ill patient, you should start a medical nutrition therapy. What do you mean by medical nutrition therapy? It consists of three things. Either you can start oral diet if patient is able to take, you can give them enteral nutrition if they are unable to take or increase chances of aspiration, or you can move forward with the parenteral nutrition. So medical nutrition therapy consists of three things. So the take-home message for the student is there is not well-defined entity for the critical care illness, but still any critically ill patient who stays more than 48 hours in the ICU should be assessed and should be considered for medical nutrition support that consists of enteral nutrition, oral diet or parenteral nutrition based on the assessment and screening. So now we move towards the second things, why we are discussing about first week in critical care, right? So irrespective of the definition, forget about the critical illness, but they having invariably some degree of inflammation when they are there in the ICU because of the primary disease, because of some secondary insult. And that leads to energy expenditure, increased energy expenditure and stimulate protein catabolism. And I already mentioned this is quite different than the starvation. So if we define what happens to these first 7 days in a critical care, so that divides into two phases. This hypermetabolic state divides into two phases. One is known as F phase, second is flow phase. So when patient there in ICU for 24-48 hours, early it will be F phase. This is a very arbitrary demarcation. There is no such things like before 48 hours, there will be no flow phase. But it's just to give you an overall idea about this. This F phase will persist for 2 or 3 days. After that, there will be a flow phase. And what is the characteristic of it? So in F phase, there is a decreased cardiac output. When there is an acute insult happens to your patient, there is a decreased oxygen demand. And to cope up with those insults, you have increased catecholamine that is responsible for increased blood glucose level, that's responsible for your hyperglycemia. And sooner, when it passes, it will turn into flow phase that is responsible for increased cardiac output, try to meet the demand supply thing, increase oxygen consumption, and the most importantly, characterized by the oxidation of the fuel source. So that's why I highlighted that in F phase, there will be no lipolysis in first 48 hours. When it passes to your flow phase, there will be lipolysis, there will be protein catabolism, and there will be immunosuppression. So initially, there is a pro-inflammatory, followed by there will be immunoparalysis things. Okay, so that is a characteristic. So in this fight, we are not going to talk about after 7 days. So we are going to get focus on this acute phase, day 1, 2, that is F phase, followed by early flow phase. Okay, and that is categorized by the catabolism. We are not going to discuss about more than 7 days where there is a balance between some anabolic and catabolic things ongoing. So my focus will be in first 7 days in critically ill patients. So with this background in mind, we'll move towards our main topic. So how we are going to do the evidence-based practice, or what do you mean by cookbook therapy? That's going to help the student to remember, and it's very important because all those things are evidence-based. So in exam, if somebody is going to ask you, this slide will going to get you help. So how you are going to start the assessment? So there are multiple markers. Some markers are based on BMI and weight, but that single weight-based assessment or BMI assessment, those are not reliable. And as you already learned through the previous speakers, like in obesity, we feel that they are properly nourished, but the lean body mass and the protein content will be quite less. Might be their fat is mal-distributed to their body. Second thing is that muscle mass evaluation. We always talk about fancy tools. We always talk about bioimpedance tools over there, CT, MRI, sonography, all those things. But the bedside availability of those tools, the skill required to assess those things. So there is no very widely accepted tool. Those are available bedside for the muscle mass evaluation, and then there is a limitation of those tools also. Third thing is that you can rely on a biomarkers. like albumin. But you have to understand, albumin should not be used as a nutritional tool in a critically ill patient, because in acute phase reactions, the albumin will get utilized. There is known as positive acute phase reactant. There are also negative acute phase reactant. So your CRP, your IL-6, your ProKal, those are pro-inflammatory markers. Those are known as positive acute phase reactant. While your albumin, it will go down because of inflammation. Those are known as negative acute phase reactant. So you can't use albumin as a biomarker for the nutritional support. And another most important thing is that even if you consider the weight, muscle mass evaluation biomarkers, the most important in critical care is about knowing the state of inflammation in your patient, because that's going to affect your all those findings, severity of inflammation, disease per se, etiology of that disease, and whether it's an acute or chronic type. So when you come to a conclusion that not the single parameters is going to give you idea what we'll do in critical care, we'll develop the score by combining all these parameters. So with those things, cannot personalize therapy based on these tools, so we come with the score. So these are the three scores that come into the picture. First one is the MUST and NRS 2002. Second one is the ESPEN GLIM, and third one is a Nutrix score. So we'll just discuss brief about those things. Already screening tool is discussed by the previous speakers. So I'll just go through the slides very fast. So in MUST score, they categorize 3 parameters. One is BMI, whether it is weight loss happens in recent area, or your disease having acute illness on degree of inflammation, based on which you categorize 0, 1, and 2, and you are giving the weighted to your nutritional therapy. While in NRS 2002, see why these tools are very helpful, because they are very easy to do, and the predictive value of this tool is quite high. So it's easiest, quickest, and the predictive value is time established. Already trial done, this shows the validity of using this tool in a critically ill patient. And ESPEN GLIM guidelines. So what's the ESPEN GLIM done? They just put these 3 isolated parameters into phenotype criteria. They knows that weight loss isolated is not reliable. They knows that body mass increase isolated is not reliable, muscle mass. So they combine these all 3 and put them in a phenotype criteria. Then they divide into stage 1, one type of phenotype, and stage B, a different type of phenotype. Along with that, they put the etiology criteria and disease burden, and they gave out to a conclusive things. And the final one is a Nutrix score. So there are the variables in the Nutrix scores. There are 6 variables: age, Apache 2, so far, number of comorbidities, days from the hospital ICU admission, and IL-6. So when you are not using IL-6, the IL-6 is not available in all the hospitals. So in such case, you can modify the Nutrix score. So if you know IL-6, modified Nutrix score, otherwise conventional Nutrix score. So if your score is 6 to 10, you label them a high risk, and this group of population having high malnutrition risk is 0 to 5, low risk, and less malnutrition risk. So that will help them. Now already speakers discuss a lot, is there any validated tool in the critical care for the screening? When they label this ESPEN guideline didn't prove the Nutrix score, the limitation of Nutrix score, if you went in the previous slide, there is no nutritional marker they had used over there, right? Because they didn't mention albumin over there, didn't mention any of the BMI over there. So that's the limitation of it. But if you go into deep, then you will get the ideas. Not all those markers are directly translated to the mortality benefit. That's why even if it is not there in Nutrix score, it's not going to make any change in the outcome of the patients. So now what is the validity of the Nutrix score now? Because the ESPEN guideline come in 2019, but the validity of Nutrix score happens afterward. So in last 3 to 4 years, there are multiple trial comes out that shows that Nutrix score can be used as a validated tool in a critically ill patient. That is a Nutrix study group that I put on the picture, where they come to a conclusion that is a reliable tool for the prognostication of critically ill patient for the malnutrition. This is another meta-analysis done that published in the Egyptian journal, where did the meta-analysis for the Nutrix score reliability and the outcome in critically ill patient. That is again a new trial, a nutritional assessment of critical illness and validated of modified Nutrix score. If you see the area under curve, the ROC AUC, that is 0.768. That is not that bad, sir. For the student, when we rely the validated tool as a reliable tool, when your AUC is more than 0.8, it considered as a good tool. Okay, it will be excellent if it is more than 0.9. So here your area under curve is 0.768. So if you go with your Apache score 2 also, that will come into this AUC, and still we are using Apache score, right, for the prognostication. So whatever we discussed in the last couple of slides, that there is no validated tool, because the ESPEN guideline mentioned those things in 2019, but at that time there was not validation. But those last 3 years, they get multiple trials that proves the validity of Nutrix score in critically ill patient. So the take-home message, no gold standard to define at-risk patient and malnourished patient in the ICU patients according to ESPEN guideline, but in last 3 years, Nutri-Score proven its validity. So we'll start now. When to start nutrition? There are two possibilities. It can be no vasopressors in your patient, can be vasopressors. So the take-home message is there. Start within 24 to 48 hours of ICU admission. Based on ESPEN guideline, take-home message for the students. When you have no vasopressors, you can start the nutrition, medical nutritional therapy, I would rather use that word, within 24 to 48 hours. But when you have a vasopressors, what should be carried out? Either you can withhold your medical nutritional therapy for 24 to 48 hours, or you can start with very low dose of enteral nutrition. Okay, so the take-home message when you have a vasopressors, hold EN till your patient is actively resuscitated or getting stable, and start low dose enteral nutrition even if you want to start. Now some intellectual critical care intensivists come into the picture and he will say, no, I want to start 24 hours as soon as possible. Why to wait for 24 to 48 hours, right? So I want to start less than 24 hours. So this is the guideline. That is a Nutria 2 trial that shows enteral versus parenteral nutrition. You can use any of one, and that was done in shock patient. And what that found was the conclusion was that did not reduce mortality or the risk of secondary infection, but was associated with greater risk of digestive complication. That means even if you start less than 24 hours, you are not going to add any benefit, but might your patient having more digestive complication when they are in a shock state, when they are on vasopressors. So please wait, 24 hours is not a long duration. Okay, you can start your enteral nutrition at 24 to 48 hours. Now the second question come to start, how to start? Whether we have to start orally, whether we have to start enteral nutrition. So there is no study that compares enteral nutrition to oral diet. And sometimes it's not feasible also, sometimes it's not ethical also. When your patient is going to take orally, why you put a ET and do it comparing the trial? When your patient is able to take, why you want to make them starve? So there is no trial that done that is like make them starve or give the nutrition and see the difference, or give them oral diet. Even they are taking oral diet and you are putting a RT and just checking it for your sake of benefit, for the outcome benefit. So the take-home message is that when your patient is able to take orally, and if it is 70% of the intake of your goal, you just allow it, oral diet. But if you are unable to meet that on a 7th day, the 70% of the caloric or protein goal, or if there is a chance of risk of aspiration and vomiting, in such cases, you have to insert your nasogastric tube or a nasojejunous tube and you have to start your enteral feeding. By default, oral diet, not reaching 70%, put a tube and start feeding. Now, second question comes to the mind, early enteral nutrition versus delayed enteral nutrition. So, what should be carried out? So, early enteral nutrition may reduce infectious complication compared to delayed beyond 48 hours. So, you can start enteral nutrition early. As the time passes, the chance of infectious complication and mortality prolongs. So, you can start within 24 to 48 hours. Now, the next question is early enteral nutrition versus early parenteral nutrition, because this is always a debate since many years. I think previous speakers already discussed about EPENIC trial, but as the time pass, we get the idea, and there is a meta-analysis done that shows that early enteral nutrition having reduction in infection, complication, shorter ICU stay and hospital stay, but there is no change in the mortality. You have to keep this word in mind. There are trials done in the previous days that shows there is a chance of reduced infection, but no change in the mortality. And there is a new trial that come into picture. That is a calorie trial. So what was that trial all about? So trial of the route of early enteral nutrition. So give patients enteral nutrition early, give patient parenteral nutrition early and see the outcome. So there is no significant difference in 30 days mortality and there is no change in the infection complication also, right? That was the concept that we thought. So why would that infection rate was high in EPENIC trial and all those things? Why they went against the parenteral nutrition? Because when you are using a parenteral nutrition, you are overfeeding your patient. You are giving over calorie to your patient. But if you are restricting the calorie intake of your patient, so if you are giving a isocaloric parenteral nutrition, in another group you are giving isocaloric enteral nutrition, the infection rate is not high with the parenteral nutrition. That's the take-home message we have to take. So if your patient is unable to take enteral nutrition, if you are unable to make any goal that you are not going to get achieved, early parenteral nutrition is not going to increase the mortality, it's not going to increase the infectious rate also, that we have to keep in mind. Now, when early PN over EN, so till now we had discussed about oral diet versus enteral, early enteral versus early parenteral, when parenteral. So when there is a contraindication of enteral nutrition, on when you have a very high nutrition risk, like your NRS 2002 score is more than 5, or when your EN is not feasible or contraindicated. So what are the conditions? So when you have uncontrolled SOAP, that is persistent over there, when you have uncontrolled GI bleeding, when your gastric aspirate more than 500 per 6 hours, definitely some will argue these magical numbers come out like 500 and why you are doing 6 hourly gastric aspirate, but that is given by the guideline. So 500 ml every 6 hourly. If it is more, probably you can consider about PN. If you have bowel ischemia, bowel obstruction, abdominal compartment syndrome, and high output fistula without distal feeding access. So these are the couple of conditions where you are trying to avoid enteral nutrition. In such cases, you can give priority of early PN over EN according to the guideline. Now again, I am an intellectual intensivist, so I will think EN versus supplementary parenteral nutrition, because that's also a possibility, right? Somebody will come with picture like I will give EN also, and if there is an inadequacy of the calorie and protein need, I'll add supplemental PN to achieve my goal. So what's the trial supporting of? So there is a top-up pilot trial, and what's the conclusion? No significant outcome difference were observed between group, including no difference in infection. Please don't do this also, it's not evidence-based. Now what's the outcome of continuous versus bolus enteral nutrition? So take-home message is continuous is better. Why? Because decreased digestive complications and decreased diarrheal risks. So continuous will be better. Now gastric EN versus post-pyloric EN is just like nasogastric tube or nasojejunal tube that we have to prefer. So they came with the conclusion, by default you have to choose stomach as a primary area. So gastric is always preferred, except you're having a higher chance of aspiration and intolerance. Intolerance despite giving prokinetic. In such cases, you have to take a help of NJ, otherwise NG is a by default in the ICU. There are some trials and meta-analysis shows there is a trend of less pneumonia when you are using NG over NG. Nasogastric or nasojejunum over nasogastric, but there is no change in the mortality, there is no change in the other outcome benefits. So by default, nasogastric. What do you mean by short term and long term? So when you are going to tell the patient you are going to require PEG tube. So if you are expecting, then it will be more than 4 weeks of enteral nutrition therapy is going to require in your patient. You can move with the PEG. Otherwise, if it is short term, you can manage with nasogastric or jejunal tube. Now the second point is that what to start. Okay, till now we decide how to start. Okay, we did the assessment, we defined our territory. Now the main thing is that what to start. So what to start divide into 3 categories like energy, protein, and micronutrient, right? So what about energy? So the take-home message is that except below energy expenditure. And what do you mean by below energy? That is less than 70% of the energy expenditure in first 3 days. Okay, and from 3 to 7 days, you are trying to achieve from 80 to 100%. Okay, probably 80% on day 7. So that is a take-home message about the energy. And how you are going to do the energy expenditure, how you are going to calculate it. So there are 2 or 3 tools. The standard gold standard thing is by doing an indirect calorimetry. Why? Because when you are rely on the weight-based equation that we normally do, because not all the centers having indirect calorimetry. But what they found out, there is up to 60% of inaccuracy when you are doing your weight-based or when VO2 or VCO2 based equation. So the gold standard is indirect calorimetry. If you don't have, then you can rely on your weight-based equation. So how you are getting personalized at this level, not a personalized, but it's evidence-based. So if you're doing indirect calorimetry, you use isocaloric nutrition. But if you don't have indirect calorimetry, like in most of India we don't, then we have to give hypocaloric nutrition. And what do you mean hypocaloric? In first 3 days, 70%, less than 70%, from 3 to 7 days, you are trying to achieve up to 80 to 100%. Now again, my brain works, and I'll come out with energy dense versus standard enteral nutrition, because I want to personalize the things. Okay, and what's the guideline and evidence behind it? So there is a target investigator. What they had done, 1.5 kilocalorie per ml, that is known as energy based, energy dense, versus 1 kilocalorie per ml, that is routine that we are doing, right? Is there any change in the outcome? So there is not higher than with the routine enteral. So there is a like neutral trial. It's a negative trial. So there is no any added advantage over energy dense versus routine. What about permissive underfeeding? So there is a permit trial, okay? And it shows that it's not associated with lower mortality. So it's better to give less rather than giving more or energy dense fluid, right? And there is one specific trial, that is the Eden trial, and where they gave the importance of tropic feed, particularly in a subgroup of patients like ALI and ARDS, where they had mentioned even if you use 500 ml, that is known as tropic feed, like 20 ml per hour you are using for 5 days, it's not going to change the outcome of the patient, it doesn't increase the mortality, because in ARDS we are more concise about the restricted fluids therapy. So even if you use less, like 500 ml for 5 days, it's not going to increase the mortality. Now, second thing is what to start protein. So we discussed about carbohydrate, now the protein. What's the take-home message? Low dose means 0.8 gram per kilogram per day for 3 days earlier. After that, from 3 to 7 days, you move to 1.2 gram per kilogram per day. So that's the take-home message. Yeah. So again, I'm an intellectual person. I will go with high versus low protein delivery, okay? And this trial came into the picture. This is not a trial, this is a meta-analysis, where they shows in critically ill patients a higher daily protein delivery was not associated with any of the improvement in the clinical or patient-centered outcome, where the protein difference was 1.3 gram versus 0.9. Somebody will argue that's not the significant difference, but the take-home message was given by the randomized control trial. So there is no added advantage of giving high protein. This is a new trial in the future that is known as effort trial, that is there in the process, that will give us a better insight, that is 2.2 gram versus standard 1.2 to 1.3. So when the outcome comes, we'll get a better idea, but till now there is no added advantage of using high protein. That's the take-home message. Now again, semi-elemental versus polymeric. I want to be more fancy about using peptide-based solution, right? When your patient having a diarrhea, I will always move towards the semi-elemental immediately. Okay, so is there any advantage and mortality benefit also there or not? And what do you mean by semi-elemental? Semi-elemental is peptide-based plus they having a medium chain triglyceride that reduce your diarrhea frequency. That was a biological possibilities by doing this trial, but that shows there is no benefit. Did not improve daily energy intake or gastrointestinal tolerance to your patient. That is a spirit trial also. That is also a negative trial. Now again, I want to combine my knowledge. So high protein hypocaloric versus normocaloric enteral nutrition. Because in critically ill patient, if you go with the pathophysiology, your patient needs more protein, less calorie, because calorie is bad. That is taught to us as a nutrition support. So this is a trial that shows there is no any change in the outcome. So please stick to your guideline. Okay, don't do all those experiments about giving more protein like 1.5 to 2 gram per kilogram and give less calorie in other patients. So normocaloric with normal protein advised by the evidence base should be followed. Then there is another trial or a combination that you can try and people did also, that is optimized calorie and high protein intake versus recommended calorie protein. Okay, and this is a trial that shows negative outcome.
I think your time's up, so we need to.
Yeah, so I'll move fast.
Yeah.
Another thing that you can personalize is volume-based feeding versus rate-based feeding. It's also a negative trial. Okay. Then there is a new thing came into the picture, that is PEPUP protocol. That is basically a Canadian protocol where they found out there are 4 different things by which the patient is compromised with the nutrition. First thing is more GRV, that is more than 500 ml. Second, your patient having diarrhea. So they came out with these 4 categories, but that also came out to be a negative trial. There is no mortality benefit with those things. So as a take-home message for the carbohydrate, in first 3 days, you have to target less than 70%. You have to reach to 100% on day 7. You can personalize your thing after 7 days, irrespective to your patient is high risk or low risk. For protein, you have to be 0.8 up to first 3 or 4 days. After that, you can reach up to 1.2 gram per kilogram up to day 7. And you can personalize your thing after 7 days. Okay, about micronutrients, there is no guideline they put for the micronutrients, but still in critically ill patient to prevent the refeeding and higher chance of refeeding, you can use the thiamine single shot to your patient. And these are the different negative trials that shows that you should not use micronutrient empirically in your critically ill patient. This is an immune modulating agent, negative trial, glutamine salamine, negative trial, glutamine antioxidant in critically ill, that was a redox trial, negative trial. Okay, selenium negative, fish oil antioxidant, glutamine negative, fatty acid, lung injury negative, meta-analysis, vitamin C negative, vitamin D negative, thiamine negative. So what is the verdict? I think last 2 slides, I'll just take 2-3 minutes more. So verdict is there, you have to do the assessment at 48 hours, start your medical nutritional therapy. If they are unable to take 70%, if there is a aspiration chances, put a tube and start enteral nutrition. This is already discussed. Continuous is better. Gastric intolerance, use erythromycin rather than metoclopramide. And consider EN versus low dose PM. So what is the change happens to the nutrition in last 5 to 10 years? So this is a paradigm shift that we can say. Early provision of high protein intake and caloric overfeeding may confirm harm. So please don't overfeed your patient. Don't give high protein in the first 7 days. Don't give high calorie. Second thing is that refeeding syndromes warrants caloric restriction. So you have to monitor your patient for the phosphate level. If it goes less than 0.63 millimole, or if the fall from the baseline will be more than 0.16, okay, in such cases you have to restrict to 500 ml. You have to supplement magnesium, phosphorus to your patient. Enteral nutrition is no longer superior over parenteral nutrition that we had discussed, okay? And previously reported benefit of glutamine, selenium, and fish oil seem to have vanished in recent study. Don't use those micronutrients empirically. So why not to deviate? Because personalized therapy, less bedside spend time, not best but at least better approach, evidence-based, helps in basic goal achievement. For inexperienced juniors and wide range of intellectual level in the critical, at least you should do this. That is evidence-based. If you are getting better, then do personalized thing. Okay? Personalized therapy seems good on theory, but whether it helps on clinical outcome is still questionable. That I already put the randomized control trial sufficient. So personalized therapy need personalized care, and that personalized knowledge and dedicated decide the outcome. I will just keep this slide because I will put those things for Dr. Rahul Pandit sir. So ultimately, take-home message is this. This is the most important slide. So for the lazy generation like me, should follow the evidence, okay? Because I hardly go to the bedside, okay? I visit the round once only as a junior. But when you become mentor, when you are quite expertise on those things, at that time you are allowed to do the personalized thing.
Can I have my slides up, please? Great, thank you. So, Dr. Balakrishna, in his typical way, talked about Russia and Ukraine, but ultimately, like Ukraine, he has confused Russia. Which side are you on, Balakrishna? My side or Ukraine's side? I don't know. And remember, whatever is the outcome of the debate, the sympathy is always with Ukraine. So that is another problem. Anyways, I think he had a very exhaustive talk. So press the green button. Thank you. What I'm going to talk about in the next 15 or 20 minutes is, does it really make a difference for nutrition to be personalized in the first 1 week of intensive care admission? And we are not talking about patients. Our 80% of ICU patients, and quote me out if I am wrong, are actually sitting and talking to the dietitian, aaj shaam ko main dosa khaungi, kal subah main vada pav khaungi, whatever is been offered. Those are not the patients we are talking about, because those patients are there just for the sake of maybe observation. They may be having a bit of an organ dysfunction which is not really requiring a lot of care. We are talking about those limited 15, 20, 30% of the patient, may depend from ICU to ICU, who are really critical, who really have a big stress. They have an induced metabolism. Their inflammatory cytokines and other metabolites and mediators are very high. And in whom we have now known that the outcomes are poor if we don't give good attention to their nutrition. Those are the type of patients we are talking about. I'm not talking about the patients who are generally in our ICU, who are sitting away chatting, they want a mobile, they want a TV and everything. This was very nicely explained by Dr. Bala. I am not going to repeat that, the 3 phases. And the acute phase then gets divided into 2 more phases, where you have an early period and you have a late period, which sort of encompasses the first 3 to 4 days. And in these 3 to 4 days is what you need to really understand whether your interventions for nutrition are actually going to make a difference in the patient's outcome. And if you don't have a good answer for that, then you should probably not be thinking about this debate at all. And I'm going to try and see whether we require to give attention to it or not, whether we have enough evidence or enough tools to assess that is a secondary question. So let's look at whether the whether the need is there to assess this early period and the late period. And then, of course, the post-acute period, there is plenty of evidence that you don't keep them undernourished for a long time. Otherwise, you will actually have a lot of problems. So what's the prevalence in Asia? Let's talk about Asia. A lot of Caucasian data exists. Let's talk about the data in Asia. And these are papers which are, again, I'm sure all of you have read through. What we now know is that prevalence of, critically ill patients who are probably undernourished or malnourished can range up to around 40% on an average. And these are associated with increased complications, mortality, length of stay, infections, higher time on ventilator. Then you may also have increased cost of care because they spend longer time in the ICUs, they spend longer time in the hospitals. So all of that does matter. So it does matter that you actually, if you don't look at the critically ill patients who are malnourished, you probably end up having a lot of problems. And money seems to be one of the bigger problems as well. We also know that a significant number of our patients who are really critically ill land up with harmful complications. And those harmful complications include a loss of muscle mass, sometimes ICU-acquired weaknesses, and a lot of that particularly happens in the first few days when they are very, very catabolic. They are extremely catabolic, and that first few days may contribute to that catabolism, may contribute to that muscle mass being lost. Of course, if you keep them undernourished to go to the point that even by day 5 or day 8 or day 9, you've not really addressed their nutritional needs, this would become much more worse. Okay? But most of the times we are able to address their needs by day 4 or day 5 because the acute phase of catabolism goes away. Our attention comes back to the nutrition. The problem is most of the intensivists, most of the dietitians, most of the physicians, emergency doctors, nurses working in ICU, first couple of days are working around the catabolism and the reasons for catabolism. And we do not pay enough attention that what is catabolism doing to this patient's proteins, what is catabolism doing to this patient's nourishment, and we often underestimate that. Now, how do we estimate that? Very difficult. We will come, I've got a couple of slides on that again, but not very impressive to sort of talk to you about the need for doing it. Now, mechanical ventilation, long-term ICU, physical function, quality of life, all of that basically matters when you have these patients. Now, modern intensive care, we have become extremely good at saving lives, but some of us are also blamed to be very expensive. We send patients home more often than what we were doing probably 20 years ago, but are we sending them in a good quality of life? Put your hands up to the number of times you have sent a patient home and said, "Shayad ghar pe thoda help lagega." You will require a nursing care at home. Why? They came to you walking. Maybe not walking may not be the right word. That might sound like a typical relative complaining to the doctor. Mera patient to chal ke aaya tha. But maybe not walking, but they did not come to you that poorly nourished, most of them, that they were not able to even take care of themselves or not even walk to a bathroom to sort of relieve themselves. But we send them home now requiring 2 people to assist them to the bathroom or maybe even have a care given at the bedside. Not even able to do the simple hygienic needs which everybody should have as a quality of life. Okay. So are we having... So we also know that most of these patients have a very poor intake of proteins. So are we actually creating victims more out of the whole process? Do we give vasopressors in ICU without measuring the blood pressure? We don't, right? If I have to give a vasopressor, within 30 seconds my register says, "Sir, 8 line dal do." Not because they want to do the procedure, but they are aware that this requires some amount of monitoring. Vasopressors cannot be just given blindly to the patients. But we don't do any nourishment, any assessment of the nourishment or nutrition, thinking that it is probably not necessary. I agree with the points discussed before that you don't wait for an assessment tool, you start feeding them. I am completely in sync with that. But what we have never asked ourselves as a question is that as intensive care doctors, have we really objectively assessed our patients? Now, there are various ways of objectively assessing nutritional needs apart from the various scores which have been talked about. You can look at a muscle mass. Ultrasound is now a tool which is sort of replaced as a stethoscope for the intensivist. We are carrying away with an ultrasound machine on the rounds. How many of us dedicatedly look at the muscle mass? The lean body mass on a CT scan or ultrasound can be easily measured. You have indirect calorimetry, you have energy expenditure which can be calculated, which will give you a realistic assessment that yes, patient may be nourished or not or under malnourished. That assessment is already done by the dietitian. It's available to you. But with this patient, whether the energy expenditure is high, where am I looking at a muscle mass like this one on the right side of the screen here, who has got a very low muscle quality as well as very low muscle mass, or am I looking at a reasonably nourished patient who has a reasonable muscle mass at the moment, and then when I look at him in 4 days time, I come to know how much he has lost. And that would be the assessment which I would like to do in an objective way. Not just say that my Nutrix score was this or my Nutrix score was that. Now this is a very good hypothesis by Paul Weschmeyer. He talks about how your energy expenditure should basically also translate into you giving more nourishment. Okay, but this needs to be studied. This needs to be studied and this needs to be actually proven that it makes a difference in the patient's outcome. We don't have that. This all looks like an hypothesis which is very nice to talk about. Now what do the guidelines talk about? Guidelines say that you give around 70% of your expected energy expenditure, which is called as hypocaloric. And then you sort of give proteins at least 1 gram or 1.3 grams per kilogram per day. Whether we are able to achieve that or not, I think number of speakers since the time I've come, everybody said that we are underfeeding the patient. We are not able to achieve that. Again, that's a very clear understanding. We don't have to really emphasize on that. You can then divide yourself and say what Dr. Balakrishnan talked about, day 1 to day 4, day 5, then a post-acute phase, then post-hospital phase, and all of those things. Really, are we able to really assess our critically ill patients in the first week as well as we are able to assess them in the second, third, and fourth week of their illness? No, the answer is no. That's the problem. We are not even assessing them. And we are thinking that it doesn't matter. It doesn't matter whether we give them hypocaloric or isocaloric. It really should not matter. This is a very nice paper which looked at endogenous glucose production. You starve healthy people for 2 days and you find that the endogenous glucose production is just under 200 grams per day. Because the body requires, there are glucose requiring organs in the body requires to produce glucose. You do a same thing to the critically ill patient. Look at the amount of endogenous glucose production which that critically ill patient has. He has almost 1.5 times more requirement for that because his organs were starved, they were hungry, there were catabolism which was going on in them. Then you partially feed them, they become better. By day 9, you are able to achieve some sort of a balance there. So there is enough evidence screaming at us that we are not looking at it properly. How to look at it is a very difficult question. That's the unfortunate truth of it. This is a very interesting study. Early feeding, it reduces mortality. Okay. Now this was said that you sort of reduce mortality, but neither the route nor the caloric intake did not matter. So you need to feed them early. The problem is that I can easily go and criticize this study. It's a non-blinded study. It's a single-centered study. It's a number of patients are extremely small. There are no power calculations which they used to actually talk about it. And groups were treated differently. The intervention arm had a special dietitian looking after them. The non-interventional arm had just intensive care doctors looking after them. It makes a big difference. How many of us ICU doctors, there are a number of them sitting here and on the stage, spend even more than 5 minutes on feeding in a day? Tell me. None of us. We might discuss 100 other things, but nutrition, feed chalu kar do. That's what it looks at. Correct? Yeah? Again, this is again from Paul Weschmeyer's paper, which talks about energy expenditure versus energy delivered. Look at a dotted line is the energy expenditure, energy delivered. And then we look at oxygen consumption, we look at the VCO2. And where are we? We are going down. And look at that digits there. This is a patient who has got stroke, who's got burns, sorry. He was 99 kilo on admission. By the end of 180 days, when obviously 85% burns, it took a long time for this gentleman to even come out of it. He has lost almost 25% of his body weight. And God knows how much of that was muscle mass because that's not been calculated. But look at what was happening with his VO2 and VCO2. It kept on slipping down. That means his muscle mass was reducing. All that body weight which he lost was the muscle mass, nothing else. Because rest of the organs are just consuming your glucose. But your VO2 and VCO2 are actually talking about how much muscle mass you are losing. So we have objective ways of doing it, but we are not. 2013, 2016, 2017, 3 papers I have put up for you. In a summary, none of it makes a difference. Whether you give them algorithm-based feeds, whether you give them hypocaloric versus normocaloric feeds, whether you give them top-up feeds, none of them have actually made a mortality difference. To see for a mortality in ICU, you will need to do one of the cardiology trials. What are the cardiology trials? Cardiologists prove that metoprolol worked. Why? Because they studied 50,000 patients. Aspirin works, they study 1.5 lakh patients. Do we have the capacity to study that kind of a patient? Every ICU in the whole world, if they're able to recruit one patient every day for the next 5 days, we'll be able to do that kind of a trial. But we just don't have that kind of a networking to actually do it. So I think simplistically putting, last 3-4 slides, if the gut works, use it. I think again, there is no big deal in that. Enteral nutrition should be preferred. Enteral nutrition probably can be supplemented with parenteral nutrition. What we need to do is we need to avoid underfeeding. That is very clearly understood. Whether you feed adequately or not is a very difficult question to answer, but you do not underfeed. You don't stop their feeds in the first 48 hours or 72 hours. Use enteral nutrition in critically ill patients. You basically will have patients who have uncontrolled shock, who have got hypoxemia, who have got several other catabolism going on, but delaying enteral nutrition will worsen their outcomes. That is very, very clear. That there is no doubt about that. This is from the Society of Critical Care Medicine guidelines, which says that start parenteral nutrition when enteral nutrition is not feasible or insufficient in high risk or poorly nourished patient. That's the only consensus which we have, whether to start them early or not. We have been sort of talking about nutrition for last 30 years, but nobody talks about it in a very, very objective way. So my last slide. Nutritional needs will vary amongst our patients. Somebody put out, I think Chandrasekhar showed that all our patients are different, just like the fingers of our hand. All our patients are different. You will need to have an objective way to assess whether first 48 hours is going to make a difference or not. Indirect calorimetry may be helpful to actually determine what is the actual energy requirement and expenditure. You can use, if you are using ultrasound, you can use ultrasound to sort of assess which patients are worsening, and you could come out with your own study. Suppose somebody works in the liver ICU, somebody works in the neuro ICU, somebody works in a cardiac ICU. You would be able to have a reasonable understanding among your population that which are the patients. In maybe years' time, if you collect the data, you'll be able to answer yourself next year that this is a group of patients requires extra attention from me and my dietitian. Prefer enteral, but use parenteral more readily when basically it is required and it's necessary. Thank you very much. I'll be happy to take questions.
Yeah, thank you, Bala, and thank you, Rahul, sir, for the excellent talk. Basically, I just want to make one comment. So, probably Bala has given more evidence, and our DNB and fellowship students will be more happy with his talk because he has covered almost all the topics. And of course, Rahul, sir, I can consider him to be one of the experts, and he has given in a lucid way the experience-based medicine. So whether it is evidence-based medicine or experience-based medicine, I'll just share a small incidence from my ICU basically. So there is a patient of around 75 years undergone the radical neck dissection. And every day after the surgery, he was remained tachycardic. We have covered his pain, we have already taken care of his fluid status, everything. But he was remaining tachycardic, and he was always complaining and swaying the head because he was complaining of, we don't realize sometimes, when the patient gets more and more conscious, he just wrote something on the paper like tea. So then we asked him whether you are a tea addict or something. This is not in the book, not in the your evidence, but ultimately I have discussed with my dietitian, and we have to give him a tea, and ultimately he remains settled down and he got discharged from the ICU. So sometimes the experience-based medicine takes over the evidence-based medicine, but of course both are complementary. So this is my take-home message.
Green tea or normal tea?
Okay, that was a very excellent presentation, both the doctors. I think all of us sitting over here, it's a mixed group. There are dietitians and there are doctors here. Just few things that I would want to highlight. Very nicely pointed out that what is very important, since morning we've been listening all the debates, screening the patient, identifying who is the critically ill patient who requires extra attention. Then comes your planning, intervention, medical nutrition therapy, all of that important. I think somewhere now, I think even the documentation part, is improving over the years, what we see. But I think one thing that all of us need to consider, not just about planning, but to look at what you are planning whether adequately the patient has got that. So when I say that, I mean that we need to go a step further, whether it is the dietitian or even our intensivist, to look at the adequacy in terms of how many interruptions are happening in feeding. I might be planning a 1 gram protein per kg body weight or 1.5 gram protein per kg body weight, but we have to see the number of interruptions which are happening, and sometimes these interruptions are the reasons why we are not able to see the effect that we need to see in a patient with the intervention. So I think this is one part that we should really focus on. Thank you.
Yeah, so what I gather from the entire thing is what he's put so much loads of evidence, it's full into my head. I think 30, 40 papers I think you showed, 40, 45 papers. But as Dr. Rahul Pandit put it very clearly, I think we just don't know. The answer is we just don't know, and the only answer is to know by collaborating together and probably running large trials that the United States and European countries do to understand whether personalization really makes a difference in the first 10 days. As of now, the verdict is not out, I feel. Anything to say, Balakrishna?
Even if you want to personalize, on what parameter you are going to get personalized? Like there are two levels. See, there is a heterogeneous population in the ICU. First of all, personalized based on assessment, personalized based on biomarkers, personalized based on microbiodata, personalized based on phenotype. But there is no any bedside or easily accessible tool by which you can personalize the person. That is the problem. Second thing is that if you want to do the micronutrient personalization, the problem is that at what dose, and there is no tool available bedside that give you an immediate idea about, like we can able to do the Procal and CRP for the infection, whether the inflammation is high or not. But what about the level of zinc, magnesium, or a selenium, or some rare micronutrients that are not available bedside? And even if you are treating them, whether they are achieving that level in the blood or not, that is also questionable. So even if you personalize micronutrient, how we are going to do that bedside?
So I'm not a fan of micronutrients. We've had so much of micronutrients in the last 2 years, all of us during COVID, that I think the soil now is enriched with micronutrients. We can keep on mining it for another 100 years.
Right,
okay,
sir.
so don't worry about micronutrients. We are talking about good proteins and calories, which can be given in 48 hours, 72 hours or not. The real answer is that we don't know. That's what we are trying to tell, that we don't know which parameter to actually look at.
Right.
We have to come out with 2 or 3 good parameters which objectively tell us that it would be the one which would probably change if the nutrition was given or not given. Study them in a large population. 100 patient, 200 patient studies are not going to be enough. We'll have to do good power calculations. In my understanding, it will run into a couple of thousand patients at least, if we have to just look at a ballpark number. And then we can come out at, yes, these are the patients with these parameters. If they come to you critically ill, and definition of critically ill is very easy. There are a number of scoring systems of how to define a critically ill patient. 80% of our ICU patients are not critically ill. That's the biggest problem. The Indian ICUs, that's the biggest problem. All of us have worked in the Western ICUs, where unless you have an organ failure, you are not in the intensive care unit. Here, you are in the intensive care unit because you don't want an organ failure to happen. That's the big difference.
So that's a perfect, any closing statement?
So the another thing is that when we are doing the screening, we want to differentiate the high risk patient and low risk patient. Even if they are high risk, okay, we are concerned about the refeeding syndrome. Means even if the patient on high risk, when you start the protein and calorie with the optimal amount, you are thinking about refeeding syndrome or a complication of optimal protein and those things. So by default, even whether they are high risk or low risk, after 7 days, you are going to individualize them based on the screening, not on first 7 days. Is it going to make any difference to categorize on first 7 days?
Refeeding syndrome is a very low occurrence. It is not a very common occurrence. Yes, somebody who has got a cancer of his digestive system, which has basically not allowed them to have adequate feeds for a long time, yes, they would be a refeeding syndrome risk. There might be a couple others like that, maybe a pseudomyxoma peritoni, which is not really a gastrointestinal system cancer, but it is something to do with the abdomen, which is not allowing them to eat. That's a different thing. But 90% of our undernourished patients or malnourished patients who are identified in ICU are not at a risk of refeeding syndrome. I don't think we should actually read into that.
Overestimation.
We should not overread into refeeding syndrome. We should feed them. We should, if you have really understood that this patient is a malnourished patient is at a high risk because he's got 1 organ failure, 2 organ failure, please go ahead and feed them, no problems.
Yeah, it's really not the definition of refeeding, and it's rather picking up a refeeding, and we hardly have seen so much of refeeding syndrome. So it's a kind of a term that has really taken the world by storm, but there's hardly anything that we've seen in the past couple of years.
Trust me, if there is a patient with refeeding syndrome, everybody will warn you before the intensivist even sees the patient. He's at refeeding, he's at refeeding
Yeah.
risk. Everybody else has known that he's at refeeding risk. So don't worry. You will come to know who is at refeeding risk.
Very often than not, practically we start first resuscitating our patients. There itself we kind of get around the battle. I call Dr. Salomi on stage to please felicitate our speakers. Thank you very much for this wonderful talk. Munazar, thank you very much. Dr. Basu, thank you very much. Thank you very much.